My name is Michelle Schweiger. I'm a pediatric endocrinologist at Cedars-Sinai. We have the exemplary kids clinic there at Cedars. The topic for this afternoon is metabolic syndrome in 47XXY, although I will be talking about other chromosome abnormalities as well. So we will go ahead and review the data on body composition, insulin resistance, and metabolic syndrome in relation to hypogonadism with 47XXY. And we'll review the data on treatment and testosterone on the impact of body composition, insulin resistance, and metabolic syndrome in those with 47XXY compared to 46XY males. And look at the relationship between 47XXY and cardiovascular system and risk for thrombosis. So this study looked at insulin resistance and metabolic syndrome in pre-pubertal boys with Klinefelter syndrome. And the patients in this study were 4 to 12 years of age. None of the patients had started puberty yet. And they looked at risk factors for metabolic syndrome. So when we use the term metabolic syndrome, what we're referring to is a constellation of factors that can increase the risk for heart disease, can increase the risk for lipid abnormalities, increase the risk for high blood pressure, type 2 diabetes, dementia, cancer, polycystic ovary syndrome, and non-alcoholic fatty liver disease. So when you hear this term, these are the constellation of diseases that metabolic syndrome refers to. So when we look at the heart, we can see the normal artery, and then the artery which has increased plaque formation, a narrow artery which increases the risk for heart disease. And so when we refer to high cholesterol, we're referring to the increased plaque formation in the heart, the narrowing of the arteries, and the increased risk for heart disease. Although it's important to know that your body does need cholesterol. Cholesterol is very important. It's actually very important for hormone formation. So as far as making estrogen and testosterone, that's all made from cholesterol. Cholesterol is also important for vitamins, such as vitamin D, so the fat-soluble vitamins. So vitamin D, which helps keep your bones nice and strong, helps with calcium regulation, is made from cholesterol. Cholesterol also helps with digestion of food, the bile acids. So our body definitely does need a certain amount of cholesterol to be able to function normally. However, when the cholesterol levels get too high, that's where we increase the risk for heart disease. So we refer to two major forms of cholesterol. One is the LDL, which is referred to as the bad cholesterol, because as you can see here in this picture, the LDL takes cholesterol and builds plaques on the heart, which increases the risk for heart disease. And so we want that level to be low. And then the HDL, that's what's referred to as the good cholesterol. And you can see why the HDL is considered the good cholesterol, because that takes cholesterol from the heart and then takes it back to the liver to get rid of it from the body. So if you have, ideally, if you have a high HDL, that could decrease your risk for heart disease. Although the HDL doesn't remove all the bad cholesterol, only about 1/3 to 1/4. So looking at insulin resistance and metabolic syndrome in these prepubertal boys with Klinefelters, so when we refer to the term insulin resistance, insulin is the hormone that's produced by your pancreas that helps your muscles use sugar for energy. So insulin resistance refers to a state where your cells don't respond well to sugar. So what happens is you need to make more and more insulin for your cells to respond to the sugar in your body. And we know that insulin resistance is one of the pre-factors that could end up ultimately leading to type 2 diabetes. And we used to think that when you develop type 2 diabetes, then you increase your risk for heart disease and liver disease and those constellations. But now we know that even the time before getting type 2 diabetes, so even in the pre-diabetes or the insulin resistant state, that's not good for your heart, your eyes, your kidneys either, that it increases the risk for disease. So it's unclear which factors increase the risk for insulin resistance and diabetes in adult men with Klinefelters. Does the risk begin during childhood? Does the increased total body fat waist circumference precede the hypogonadal state? Or does the hypogonadal state predispose to increased total body fat? So in this study, they looked at the physical exam features in boys with Klinefelter syndrome compared to controls, and you could see that there was 89 boys with Klinefelter syndrome and 34 control, and the two groups were very similar, except the group with Klinefelter syndrome was taller, and they also had significantly higher waist circumference in the control group. So even in this pre-pubertal population, the waist circumference is wider in the pre-pubertal group with Klinefelters. Then they looked at fasting lipid and glucose values in boys with Klinefelter syndrome compared to normative data. And you can see that the LDL, so as far as the LDL cholesterol, that 37% of the patients with Klinefelters, of the subjects with Klinefelter syndrome had high LDL levels. You could see that the triglycerides were high in 15%, and 65% had low HDL levels, which is the good cholesterol. So in this pre-pubertal population of boys with Klinefelter syndrome, that they already are having lipid abnormalities. So 8% of them had 3 of the features for diagnosis for metabolic syndrome. 36% had 2 of the components for metabolic syndrome, and 34% of them met 1 component for metabolic syndrome, so either a low HDL, a high waist circumference, or elevated triglycerides. So looking at insulin resistance and metabolic syndrome in these pre-pubertal boys with Klinefelter syndrome, so the red box indicates subjects who fit criteria for metabolic syndrome. We could see at very young ages. So you can see the red box as early as 5 years of age, 7.5 years of age, that these children with Klinefelter syndrome are meeting the diagnosis for diagnosis of metabolic syndrome. And this arrow right here at 2.5 is kind of the cutoff for insulin resistance. So we said insulin resistance is when your pancreas is having to make more insulin to take care of the sugar that comes into the body. So we could see at that a very high percentage of these subjects actually had elevated levels of insulin resistance, which is a significant risk factor for the development for type 2 diabetes and other components of metabolic syndrome. So we know that in this large cohort of prepubertal boys as young as 4 to 12 years with Klinefelter syndrome, that 24% had insulin resistance, 7% had metabolic syndrome, and that in this study they also found that the boys with Klinefelter syndrome had decreased activity compared with age-matched controls. So boys were all prepubertal, but yet appeared to have increased waist circumference and increased risk for metabolic syndrome is kind of the take-home message for this study. And this suggests that the increased total body fat and waist circumference comes before the hypogonadal state, or that subtle hypogonadism in early life has later effects on total body fat mass. So this next study looked at gonadal function associated with cardiometabolic health in prepubertal boys with Klinefelter syndrome. And again, the patients in this study were, again, 4 to 12 years of age. And the majority of the subjects in this study, 95%, were 47XXY, but there was also a smaller percentage that were 47XXY, 46XY, or 48XXYY. And the majority of subjects were Caucasian, but also a subset that were African American, Hispanic, Asian Pacific Islander, and other. 62% were diagnosed prenatally, 6% from birth to 2 years, and 31% from 2 to 12 years. So what was interesting in this study, because it looked at prepubertal boys, they did already find a certain amount of gonadal dysfunction. So the FSH, which is kind of a marker for how the testes are working, was actually elevated in 20% of these subjects. So the higher FSH levels are associated with less functioning of the testes or the gonads. And LH was lower than expected. So the total testosterone was below the expected range for age in nearly half of these boys that were not yet in puberty. And so this supports the hypothesis that perhaps the androgen levels or the testosterone levels are lower in these boys even beginning in the time before they start pubertal development. They looked at anti-Müllerian hormone and inhibin B, and those are kind of factors on fertility and testicular function. And they found, and so inhibin B is a marker of Sertoli cell mass, which is made in the testes, and also looked at anti-Müllerian hormone production. And they found that those boys that had reduced inhibin B, so you can see in the graph on the bottom over there, so more affected gonadal function was associated with more factors in metabolic syndrome. So you can see that the lower inhibin B had, the subjects who had lower inhibin B also had more features of metabolic syndrome, which increases the risk for heart disease. And so there's a high prevalence of cardiometabolic risk factors, so increased waist circumference, dyslipidemia, insulin resistance, and there's evidence of prepubertal gonadal dysfunction. And this was independent of age and body mass index. So it's speculated that even in boys who are prepubertal, that's associated with increased markers for cardiometabolic risk or metabolic syndrome. So this is another study that looked at the use of oxandrolone, which is an anabolic steroid, on cardiometabolic health in boys with Klinefelter syndrome. And in this study, there was 93 subjects, and they were randomized to either get oxandrolone or not get oxandrolone, and there was some dropout. So there ultimately ended up being 38 controls and 38 in the oxandrolone group and 41 in the control group. And we can see that the use of oxandrolone in the prepubertal period was initially, it did not seem to affect body fat, but after about a year, there was some improvement in decreasing body fat in this prepubertal population with Klinefelter syndrome. And also was associated with decreasing A1C, triglycerides, and blood sugar. So looking at the typical description of a man with Klinefelters, typically is described as tall, slender, low muscle mass, narrow shoulders. And perhaps this is part of the reason why 75% of men with Klinefelter syndrome are missed in diagnosis until later in life. Because this is a man that was diagnosed at 35 years of age with Klinefelter syndrome that presented with difficulty with fertility. And you can see that he actually has pretty significant muscle structure. He's got nice hair distribution, and so doesn't quite meet the textbook description of what Klinefelter syndrome looks like. So we know that metabolic syndrome is increased fourfold. There's a fourfold increase in the risk of metabolic syndrome in those with Klinefelters compared to men who do not have Klinefelters. And in this study, they looked at the different karyotypes of patients with Klinefelter syndrome. The majority were 47XXY, and then a smaller percentage with other karyotypes. And this study was the largest study in Korean hospitals. So this was 11 hospitals in Korea between 1994 and 2014. And these were newly diagnosed men with Klinefelter syndrome greater than 18 years of age. And in this study, they compared testosterone levels in men with Klinefelter syndrome that were obese versus non-obese, which is the third line from the bottom. And you can see that the obese males with Klinefelter syndrome actually had a lower testosterone level than the non-obese males. And this was prior to starting treatment with testosterone. And in this study, they found that testosterone is an independent factor. So irregardless, so lower testosterone levels were associated with a higher body mass index, so more being overweight, and also with a higher fasting plasma blood sugar. So your fasting blood sugar, a high fasting blood sugar is associated with an increased risk of developing type 2 diabetes. So a fasting blood sugar of greater than 100 is considered elevated, and anything over 126 we use to diagnose type 2 diabetes. So we know that low testosterone levels in men with Klinefelter syndrome can be associated with increased risk for being overweight and also increased risk for prediabetes. And it's speculated that this lower testosterone level decreases the muscle mass, it increases the truncal adiposity, so fat over the stomach, and also increases the free fatty acids that increase the risk for metabolic syndrome and the development of type 2 diabetes. So we know that the obesity epidemic in the United States has continued to increase since the 1980s. And there are several different definitions of how we diagnose metabolic syndrome depending on which criteria. But essentially, fasting blood sugar of greater than 100 or 110 is considered impaired fasting glucose, triglycerides greater than 150, an HDL cholesterol of less than 40, or a blood pressure greater than 130 over 85 are some of the components that can be used to diagnose metabolic syndrome. And so this study was entitled Metabolic Syndrome is Frequent in Klinefelter Syndrome and is Associated with Abdominal Obesity and Hypogonadism. And this study looked at 71 patients with Klinefelter syndrome. 35 of them received testosterone treatment, and there were 71 in the control group. And they looked at the body composition using DEXA scan, fasting blood sugars. They looked at insulin, C-reactive protein, and analyzed the two groups. And we know that in this study, this was an interesting study because they found that in Klinefelter syndrome, the patients have 8% more 8% more truncal fat. That they have 8% more truncal fat than men that do not have Klinefelter syndrome. So truncal fat is the fat on the stomach. And you can see that that's the upper curve on the top. So the upper line is the males with Klinefelter syndrome. And we know that the abdominal obesity is one of the major risk factors for developing metabolic syndrome. And so in this study, they looked at risk for diabetes and prediabetes in males with Klinefelter syndrome versus control, and you could see the substantially increased risk for metabolic syndrome, diabetes, impaired fasting glucose in those with Klinefelter syndrome compared to the control. And then it was looked at to see as far as treatment regimens offered to men with Klinefelter syndrome. And you could see that if you compare the U is the untreated males with Klinefelter syndrome, and the T is the treated males with Klinefelter syndrome. And you can see that even those men who are treated with Klinefelter syndrome, that that there's a high percentage that are untreated, that compared to controls, so that's in that upper graph right there, that they statistically have lower testosterone levels, and the LH levels made by the brain, and that's generally lower with the optimal dose of testosterone, so the LH level is higher. So when we are treating males with Klinefelter syndrome, that there is concern that perhaps we're inadequately treating them. So in this study, they looked at metabolic syndrome in Klinefelter syndrome associated with abdominal obesity and hypogonadism, and also found that the strongest predictor was adiposity and truncal fat, and that half of these subjects met criteria for metabolic syndrome. However, only 10% of the controls that did not have Klinefelters met the criteria for metabolic syndrome. And they also looked at CRP, C-reactive protein, which is a marker for low-grade inflammation and a predictor of cardiovascular disease. And they found that the CRP was also significantly increased in Klinefelter syndrome patients. And it's speculated that perhaps adiponectin, so adiponectin is produced by your adipose tissue, and higher adiponectin levels are associated with lower rates of obesity and lower rates of heart disease. And we know that giving treatment with testosterone actually suppresses your adiponectin levels. So one of the thoughts is that with Klinefelter syndrome, that when we are treating them with the testosterone, that it does reduce the adiponectin levels, which can be a risk factor for increasing adiposity and ischemic heart disease. And looking at other risk factors for development of diabetes in patients with Klinefelter syndrome, so we know that one of the major risk factors is rapid weight gain. And we know that even with a normal body mass index, that one of the predictors of increasing risk for metabolic syndrome and type 2 diabetes is actually just the speed of the weight gain. And you can see in this study, they looked at 9 different males with Klinefelter syndrome, and you can see, and they followed them through time, and you can see that the majority of them had a very rapid rise in body mass index. So in the Klinefelter group, the BMI dramatically increased in the 9 patients during follow-up, which could also be a risk factor for the development of metabolic syndrome. And this study looked at males with a diagnosis of diabetes and the different karyotypes, and you can see that, and looked at as far as treatment, so some were treated with insulin and others were treated with metformin. And they found that the incidence of diabetes in 47XXY was 12.5%, but if you actually looked at the other karyotypes, so 46XY, 47XXY was associated with a 57.1% incidence of diabetes. So as far as the other karyotypes, there's a higher rate of developing diabetes. So in studies, besides males that have Klinefelter syndrome, we know that low testosterone is associated with increased cardiovascular disease and type 2 diabetes. It's associated with increased risk for atherosclerosis, cardiovascular disease, metabolic syndrome, and that when they've looked at studies have shown that high prevalence of low testosterone in men with diabetes. So it's thought that the more medical problems that the man has, the more stress on his body and the lower testosterone level will be. So we can see that there's it's not just a one-way relationship. The relationship goes both ways. So we know that that low testosterone level can be a risk factor for metabolic syndrome, and at the same time, some of the components of metabolic syndrome can increase the risk for low testosterone. So it's a bidirectional relationship. And we know that increased weight gain, so increasing in the size of the adipose tissue, what happens is it makes testosterone get converted into estrogen. And so that is one of the risk factors for lower testosterone levels in males with XXY. And also the increased adipose tissue increases the pro-inflammatory cytokines. So TNF-alpha, IL-B1B, IL-6, and these pro-inflammatory cytokines also end up sending messages to the brain to decrease testosterone levels. So it's speculated that these are two of the physiologies of why the increase in the body mass index, or the more fat tissue, is associated with lower testosterone levels in males with XXY. And in men who do not have XXY, it's also found that low testosterone level is also associated with increased mortality. And these were several different studies that showed higher mortality in men with lower testosterone levels. So testosterone replacement in hypogonadal men with metabolic syndrome or type 2 diabetes helps promote insulin sensitivity with or without having type 2 diabetes. And several studies report a decrease in A1C levels in men with diabetes. So the hemoglobin A1C, if you hear this term, it refers to kind of your average blood sugar over the last 2 to 3 months. And the A1C refers to the amount of sugar that's attached to your red blood cell that helps carry oxygen through the blood. And so a higher A1C tells you that your average blood sugar has been running at a higher level. And so we use a hemoglobin A1C of 6.5 as kind of the cutoff for diagnosing type 2 diabetes. But we know that even with an elevated A1C before the diabetes range, so pre-diabetes, we consider an A1C of 5.7 to 6.4%. So these studies have found that testosterone replacement helps improve the A1C. They also found that testosterone replacement helps reduce body fat mass and waist circumference, and also helps with total cholesterol and LDL. However, it does not seem to have as much of an impact on triglycerides. And the HDL can actually end up going down, which is not good. Lipoprotein A has the strongest possible positive correlation with premature coronary artery disease than any other component in lipid profile. And it's been found to have a fall significantly after testosterone treatment of men with metabolic syndrome or type 2 diabetes. So this was a randomized trial of testosterone replacement in hypogonadal men with metabolic syndrome and type 2 diabetes. And you can see that the fasting blood sugar improved once there was treatment with testosterone. And there was also a decrease in the insulin level as well, and also an improvement in the waist circumference. So this study, this paper looked at leg ulcers associated with Klinefelter syndrome, and this was a 38-year-old man who presented with bilateral leg ulcers, who had a history of having type 2 diabetes for 3 years, and he was treated with local wound care. And on examination, the patient was noted to have gynecomastia and small testes, about 10 mLs, and that's what prompted to do a karyotype, and the karyotype ended up revealing Klinefelter syndrome, and then testosterone replacement was started, and once they started testosterone replacement, there was a 75% reduction in the ulcer size. So perhaps just helping pubertal development and cardiometabolic health, that there's benefits to testosterone as far as there's other possibilities for the use of testosterone as far as ulcers in the leg. So this was a recent study that looked at epicardial fat, so this is fat around the heart. And what was interesting in this study was that when you compared the non-obese to the obese males compared to the Klinefelter syndrome group, that you could see that even in that the Klinefelter syndrome group still had a higher amount of fat around the heart than the non-obese population. So even in our males who have a normal body mass index, that as far as risk for heart disease is still higher, that they're still found to have a higher amount of epicardial fat or fat around the heart. So knowing that there is that there's a fourfold increased risk for metabolic syndrome in those with Klinefelters, what are some of the things that we can do to help decrease the risk for metabolic syndrome, development of type 2 diabetes, and heart disease? So one of the things that we can do is to decrease our intake of processed sugars. So kids ages 2 to 18 should have less than 25 grams or 6 teaspoons of added sugar daily. And then just kind of being aware of the amount of added sugars that are added to products. So this is just, one example. So we know that we said less than 6 teaspoons. So we see that just in a 20-ounce cola, that there's 16 teaspoons of added sugar. And then just kind of being aware of, we talk about physical activity and exercise to help combat metabolic syndrome, but just also paying attention to dietary intake because, as far as how much physical activity that it would take to burn off 1 20-ounce of cola, so it would take 55 minutes of moderate to vigorous cardiovascular exercise to just burn off 1 can of Coca-Cola, and then kind of comparing other processed foods as well. So like we said, 1.87 kilometers. So one medium McDonald's fries would be 5.97 kilometers. A burrito would be 11.99 kilometers. Lay's chips would be 10.47 kilometers. So this is just evidence that you can't outrun, a bad diet. So as far as our diet, we used to think that a calorie is a calorie, but now the recent research has shown that it's not just about counting calories, but it's also looking at the nutrients within the foods that we eat. So when you have like a 20-ounce cola, what happens is it goes into the stomach, and then that sugar goes directly into the liver, and then the liver ends up with all this sugar. The liver starts telling the pancreas, release insulin. A lot of insulin is released from the pancreas, and then right away this ends up converting into fat cells, and these fat cells end up leading to fat around the liver and the heart, which increases the risk for metabolic syndrome. However, if you have like a diet lower in sugar, higher in fiber, like let's say like a handful of cashews, then that stays in your stomach for a longer period of time. There isn't as much of a rise in your blood sugar, and so the liver doesn't end up sending as much of a message to release more insulin, and so physiologically, this ultimately ends up leading to lower insulin levels, decreasing the risk for metabolic syndrome and prediabetes. And then also looking at, caloric density. So we know that, like this diagram shows 400 calories of oil compared to 400 calories of beef and 400 calories of vegetables. So you can see that the vegetables end up spreading more through the stomach and stimulating the stretch receptors in the stomach. So when we eat, the stomach gets a signal that it got food, and these stretch receptors end up sending a message to the brain that we're not hungry anymore. So when we have foods higher in fibers, then we're able to fill more of those stretch receptors and also get earlier satiety signals. And so we know that this increased risk for high glucose foods ends up increasing the free fatty acids, and also just chronic stress can increase your cortisol levels, your insulin levels, and lead to more fatty acid synthesis. And so one of the risks with metabolic syndrome is non-alcoholic fatty liver disease. So you can see that with a healthy liver, that you can end up, with high glucose loads with non-alcoholic fatty liver disease, and then this ends up getting turned into non-alcoholic steatohepatitis, which is still reversible, but then the end stage is cirrhosis of the liver, which is not reversible. So, so some of the other habits for healthy kids is, an hour of physical activity a day, less than 2 hours in media, so 5 servings of fruits and vegetables, healthy snacks, 3 servings of dairy, 2 glasses or bottles of water per day, less fast foods, and then just being mindful of portion sizes. And then, just as far as sleep and positive thinking, and ultimately feeling better. So in summary, we know that testosterone deficiency is a predictor for abdominal obesity and metabolic syndrome, that testosterone plays a role in metabolic syndrome and type 2 diabetes by increasing the muscle mass and decreasing abdominal obesity. However, we know that testosterone treatment by itself does not fully correct the abdominal obesity and the truncal fat that we see in Klinefelter syndrome, and that this increased fat mass is actually present at a very young age and suggests that possibly genetic abnormalities or testosterone deficiency at that age can be factors. We'll need to do future studies in this area to gain more information and know about the effects of testosterone on cardiovascular health and better understand the pathophysiology between testosterone and metabolic syndrome. Thank you.